Hi all, this is Amy Robillard here, 6157. I'm doing my clinical at Garrity Family Practice. I'm going to tell you about LL today. His chief complaint is, I feel really dizzy. He's a 25-year-old African American male who presents with persistent dizziness for the past 2 hours that he says just came out of nowhere. He had just finished a typical morning workout and was sitting sipping a protein drink when he suddenly started feeling like the room was spinning. He says sudden movement does worsen the vertigo, but denies any specific head movements that precipitate the symptoms. He does feel somewhat unbalanced. He complains of some nausea, but no vomiting, and a mild headache above both of his eyes with no photophobia or phonophobia. He reports mild left ear fullness times a day, but no tinnitus or hearing loss. No changes in vision, weakness, paralysis, numbness, lightheadedness, loss of consciousness, or neck pain. Says he hasn't had any recent neck trauma, but he estimates a history of about 5 or 6 lifetime concussions, no history of migraine, no recent URI or sick contacts, and admits to driving himself to clinic today, but says all he wants to do is close his eyes and lay still. He reports for a medical history, seasonal allergies, been no residual deficits from his multiple head injuries. Surgical history is non-contributory to this complaint. Uses no prescription medicines, occasional use of OTC NSAIDs, and specifically denies recent antibiotic use. His family history is significant for a father with hypertension and hyperlipidemia, but denies any family history of CVA or known atherosclerotic disease. He's a single guy, works as a professional athlete, and uses no alcohol or tobacco. Constitutional for the review systems states he was feeling well up until that morning. The review system was mostly covered in the HPI, no additional skin, cardiac, pulmonary, GI, or MSK complaints. Neurologically, he denies feeling faint or like he's going to pass out. Says he has no trouble walking, but does feel a little off balance as concentrating is difficult from the dizziness. On exam, he was visibly uncomfortable, holding his head low in his hands. His eye contact was poor, saying he preferred to keep his eyes closed because this helped with the perception of the room spinning. His vitals were normal, including normal orthostats. Nothing abnormal on HE and T exam. His hearing was intact, no spontaneous nystagmus. And I obviously focused on a thorough neuro exam. There were no abnormalities, including a negative Dix-Hallpike maneuver. So our assessment, LL is an otherwise healthy African-American male presenting as visibly uncomfortable with report of acute onset of severe vertigo, nausea, and subjective instability. The physical exam was completely normal. We decided the likely cause of the vertigo was vestibular neuritis, and this is where the cochlear nerve is affected, and the precise cause of the swelling isn't well understood, but some have suggested that this is a viral cause. We ruled out a vascular event in the CNS because there were no focal neurologic symptoms, and patient had no prominent risk factors for stroke, and his blood pressure was normal. Other diagnoses considered were migraine, benign paroxysmal positional vertigo, and Meniere's disease. So no further diagnostics are indicated. We started him on a prednisone taper for 10 days, starting at 60 milligrams for 5 days and tapering from there. We recommended meclizine 25 milligrams 3 times a day for severe vertigo and Tylenol for his headache. We reassured him that most patients with acute vertigo recover spontaneously over a period of about 3 weeks, and severe symptoms usually only last a day or two. We wanted to see him back in 2 days. If no improvement, we'd consider neuroimaging and possibly a PT referral for vestibular rehab, which can speed up recovery. We advised him to avoid driving while he was dizzy and made arrangements for him to get a ride home from the office. So the principal differential diagnostic of concern in a patient presenting with vertigo is a vascular event in the central nervous system that affects the cerebellum of the brainstem. The literature suggests that a head thrush test is usually negative in stroke, but positive in vestibular neuritis. I didn't do this test when assessing LL, but I kept seeing it in the literature about vertigo, so I was curious about it. So the article I looked at this head thrust test, which is also termed the horizontal head impulse test. What? Sorry, that video just went blank. So at rest with this head thrust chest, the patient is asked to fixate on a distant target, and the patient's head is rotated rapidly by the examiner like that to one side, and in a normal response, the eyes remain fixed on a target. In an abnormal response, the eyes are dragged off target, requiring a corrective gaze shift once the head stops moving, and then the test is repeated on the other side. So the study I looked at, the objective was to assess the diagnostic accuracy of this H-HIT test in distinguishing a peripheral cause from a central cause of vertigo. So the study looked at 43 patients with vertigo over a period of 6 years, and the results showed that 100% of patients with vestibular neuritis had a positive or an abnormal H-HIT test, and 91% of patients with stroke had a negative or normal H-HIT test. So the conclusion was that patients with stroke can have an abnormal H-HIT test, so the sign can't be solely relied upon to rule out stroke. Nonetheless, it's a useful bedside test when acute vestibular neuritis is suspected, and the results do suggest that if the H-HIT is normal, vestibular neuritis can potentially be ruled out. Thanks for your time.